Welcome to our session on infective endocarditis, commonly abbreviated as IE. This is a serious cardiovascular infection that every physician must recognize early, as delayed diagnosis can lead to devastating complications, including heart failure, stroke, and death. Infective endocarditis sits at the intersection of cardiology, infectious diseases, and sometimes dentistry. Today, in Part 1, we'll explore what IE is, understand predisposing factors, identify the causative organisms, and learn about the complex interaction between microbes and the host. Infective endocarditis is defined as infection of the endocardium of the heart caused by microorganisms, predominantly bacteria, though fungi can also be involved. Now, which cardiovascular structures can be affected? Several locations. First, the atrial and ventricular endocardium, the inner lining of the heart chambers themselves. Second, and most commonly, the cardiac valves. This is the classic location, particularly the mitral and aortic valves on the left side of the heart. Third, large intrathoracic vessels near the heart can be involved. Finally, intracardiac foreign bodies are particularly vulnerable. This includes prosthetic valves, artificial heart valves, and pacemaker leads. These foreign materials provide surfaces where bacteria can adhere and establish infection. The key concept is that IE represents infection on endothelial surfaces within the cardiovascular system, creating vegetations, masses of bacteria, inflammatory cells, and platelets that can damage valves, embolize to other organs, and cause systemic illness.
Let's see a classic case that illustrates prosthetic valve endocarditis. A 65-year-old man with a history of hypertension and aortic regurgitation underwent surgical replacement of his aortic valve 2 weeks ago. He was discharged but now returns to the emergency room just a few days after discharge with fever, severe body weakness, and mild shortness of breath. This timeline is critical. Symptoms appearing within weeks of cardiac surgery should immediately raise suspicion for prosthetic valve endocarditis. Let's examine his vital signs. Blood pressure 112/64 of a millimeter of mercury, relatively normal. On physical examination, he appears ill, is in mild respiratory distress, and has a systolic murmur. The presence of a new or changed murmur in a febrile patient with cardiac history is a red flag for endocarditis. The clinical approach is appropriate. The patient is admitted to the hospital. Empiric antibiotic treatment is started immediately, and critically, blood cultures are obtained before antibiotics are given. This sequence is essential. Always get cultures before starting antibiotics when IE is suspected. This case represents early prosthetic valve endocarditis, occurring within 60 days of surgery, typically from perioperative contamination. Infective endocarditis doesn't occur in normal hearts randomly. There are specific predisposing factors that increase risk. Let's understand them. Valvular lesions are major risk factors. This includes valvular insufficiency, where valves don't close properly, and stenosis, where valves don't open properly. These conditions create non-laminar blood flow, meaning turbulent rather than smooth flow. Septal defects, holes in the heart wall, create high-velocity jets of blood that damage endothelial surfaces. These are called jet lesions and are particularly prone to infection. Direct trauma to the endocardium, such as from indwelling catheters, central lines, or cardiac procedures, creates entry points for bacteria. Intravenous drug abusers have very high risk. They repeatedly inject potentially contaminated substances directly into their bloodstream, often using non-sterile techniques. Congenital or acquired heart problems provide abnormal surfaces and blood flow patterns. Poor dental hygiene is important because dental procedures, or even routine toothbrushing, can cause transient bacteremia with oral flora. Prolonged hospitalization increases exposure to healthcare-associated bacteria, particularly with indwelling devices like catheters and central lines. The common theme is that anything disrupting normal endothelial surfaces or introducing bacteria into the bloodstream increases IE risk. Let's understand the mechanism linking these predisposing factors to infection. Turbulence of intracardiac blood flow resulting from valvular abnormalities, septal defects, or prosthetic materials leads to further irregularities of the endothelial surfaces. Think of it like repeated water damage to a surface. It creates more rough spots. These irregular, damaged endothelial surfaces facilitate platelet and fibrin deposition. Platelets and fibrin accumulate at sites of endothelial damage, creating what we call non-bacterial thrombotic endocarditis or sterile vegetations. These sterile platelet fibrin deposits then provide an ideal surface for bacterial adherence. When bacteria enter the bloodstream from any source, they can stick to these deposits and establish infection, converting sterile vegetations into infected vegetations. In intravenous drug users, the mechanism is more direct. They introduce contaminated drugs or bacteria directly into the circulation, which can seed abnormal cardiac surfaces or even sometimes normal valves, particularly the right-sided tricuspid valve. This table is crucial for understanding which organisms cause IE in different patient populations. The organisms vary significantly based on risk factors. For native valve endocarditis, infection of the patient's own natural valves, the most common organisms in order of decreasing importance are oral streptococci and enterococci, followed by Staphylococcus aureus, then coagulase-negative staphylococci, gram-negative enteric rods, and fungi, mainly Candida. The predominance of oral streptococci reflects their entry through dental procedures or poor oral hygiene. For intravenous drug users, the pattern shifts dramatically. Staphylococcus aureus is number 1. These patients frequently develop S. aureus bacteremia from skin flora contaminating injection sites. This is followed by oral streptococci and enterococci, then gram-negative rods, fungi, and coagulase-negative staphylococci. Remember, IVDU commonly affects the right-sided tricuspid valve. For early prosthetic valve endocarditis, occurring within 60 days of surgery, coagulase-negative staphylococci are most common, reflecting perioperative contamination from skin flora. Then S. aureus, gram-negative enteric rods, oral streptococci and enterococci, and fungi. For late prosthetic valve endocarditis, more than 60 days post-surgery, the pattern resembles native valve, i.e., oral streptococci and enterococci-led, followed by coagulase-negative staphylococci, S. aureus, gram-negative rods, and fungi. Finally, culture-negative IE involves fastidious organisms that don't grow on routine culture media. Remember the HASEC group: Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella kingella. Also Mycoplasma, Chlamydia psittaci, Coxiella burnetii, which causes Q fever, Bartonella species, Trophorrhima whippley, and Aspergillus. Understanding these patterns helps guide empiric antibiotic therapy before culture results return. This diagram illustrates the diverse sources and routes of infection leading to IE. Common sources include dental procedures or poor oral hygiene introducing oral streptococci, skin infections or IV drug use introducing staphylococci, gastrointestinal or genitourinary tract procedures introducing enterococci or gram-negative organisms, indwelling catheters serving as bacterial entry points, and cardiac surgery directly introducing organisms during prosthetic valve placement. The key concept is that transient bacteremia, bacteria temporarily in the bloodstream, occurs commonly from many sources. In healthy individuals with normal hearts, these bacteria are quickly cleared by the immune system. However, in patients with predisposing cardiac factors, bacteria can adhere to damaged endothelial surfaces and establish infection. This explains why we give prophylactic antibiotics before certain high-risk dental procedures in patients with prosthetic valves or previous endocarditis. We're trying to prevent or reduce bacteremia during the procedure. Understanding the source helps identify the likely organism and guides antibiotic selection. Infective endocarditis results from complex interactions between host and microbial factors. Let's examine both sides. Host factors that influence susceptibility include: first, the vascular endothelium. Intact endothelium resists infection, but damaged endothelium with platelet fibrin deposits facilitates bacterial adherence. Second, the immune system. Both helps fight infection and contributes to some complications through immune complex formation. Third, hemostatic mechanisms. The clotting system. Platelet and fibrin deposition creates the substrate for infection, but also attempts to wall off bacteria. Fourth, cardiac anatomic characteristics. Abnormal anatomy, prosthetic materials, and turbulent flow all increase risk. Now the microbial factors that enable bacteria to cause endocarditis. Surface properties, specifically adhesins, that allow bacteria to stick to damaged endothelium or prosthetic materials. For example, streptococci produce surface glucans and dextran that facilitate adherence to fibrin platelet deposits. S. aureus possesses clumping factor A, also called fibrinogen-binding protein A, and fibronectin-binding protein A. These allow it to bind to fibrin and damaged tissue. Coagulase-negative staphylococci produce slime or biofilm that helps them adhere to prosthetic materials and resist antibiotics. Enterococci express FEMA surface antigen that aids in adherence. Beyond adhesins, bacteria also produce enzymes and toxins that damage tissue, evade immune responses, and help establish infection. Understanding these factors explains why certain organisms preferentially cause endocarditis, and why treatment requires prolonged courses of bactericidal antibiotics.